Coronary artery anomalies. Seoul National University Hospital. Department of Thoracic and Cardiovascular Surgery. Coronary artery anomalies. Incidence, 1 to 2% of the population including minor. Major anomaly is less than 1% of CHD. 1. Major anomaly is 2. Minor variations. Coronary arteriovenous fistula, high takeoff. Anomalous origin from PA, anomalous circumflex artery origin. Single ostium or multiple ostia in left coronary artery. Other aortic sinus. Right coronary artery, hyperplastic proximal coronary artery. Both coronary arteries, congenital proximal or distal stenosis, coronary artery from the posterior. Aortic sinus. Ventricular origin of an accessory coronary artery. Coronary artery anomalies. Major categories. 1. Coronary arteriovenous fistula. 2. Anomalous connection of left or right coronary artery to pulmonary artery. 3. Anomalous origin of a main coronary artery from the aorta. Coronary artery anomalies. Pathophysiology. The anomalous origin of the left coronary artery on the main pulmonary artery leads to reversal of the left coronary arterial flow. This anomalous circuit results in coronary steal, myocardial ischemia, left ventricular dysfunction, and congestive heart failure. Coronary arteriovenous fistulae between the left or right coronary arteries and the right heart chambers or the pulmonary artery also create a coronary steal phenomenon and myocardial ischemia, coronary arteriovenous fistula. Definition: direct communication between a coronary artery and the lumen of any one of the four cardiac chambers or the coronary sinus, or its tributary vein or SVC. Pulmonary artery or pulmonary veins close to the heart. History. Krauss, first description in 1865. Trevor, first autopsy report in 1912. Byork and Crawford. First report of surgical correction in 1947. Fell, first report of correct diagnosis and surgical correction in 1958. Swan, first report of surgical correction by CPB in 1959. Coronary AV fistula morphology. 1. Coronary artery site, dilated, elongated, serpiginous. Right coronary A, 50-55%, left coronary A, 35%. Both, 5%. 2. Site of fistulous connection. Right ventricle, 40%. Right atrium, 25%. Pulmonary artery, 15 to 20%. Coronary sinus, 7%. SVC, 1%. Left atrium, 5%. Left ventricle, 3%. Other, rarely. 3. Size and multiplicity of the fistula. 2-5 mm fibrous margin, single or multiple opening. 4. Cardiac chamber, dilation in atrial, venous drain site. 5. Bacterial endocarditis, 5%. 6. Associated lesions, most occur as isolated lesions. Coronary AV fistula natural history. The fistula, if not present at birth, develops early in life. Likely small fistulae remains small and moderate fistulae slowly increase in size, although there may be little change over a 10 to 15 year period. Onset of dyspnea, heart failure, and angina can occur in young patients with large fistula. The maximum incidence of congestive heart failure occurs in the 5th and 6th decades. Spontaneous rupture and closure is very rare. Coronary AV fistula clinical features and diagnosis. 1. Presentation, most present late age in life. 2. Symptoms, asymptomatic in young age. mild cardiomegaly. Plethora on chest X-ray. DOE from lieutenant to right shunt. Angina, 7%. Myocardial infarction, 3%. Congestive heart failure, 12–15%, in old age. 3. Diagnosis, continuous murmurs. EKG. Chest radiography. Echocardiography. Cardiac catheterization, and angiography. Coronary artery, AV fistula. Coronary AV fistula technique of operation 1. Closed without CPB. When termination of a major coronary artery branch into an easily accessible site. When CPB is used. Indications: 1. When artery is dilated and tortuous and relatively inaccessible as an avenue groove. 2. When their fistula is in the course of coronary artery. 3. When an aneurysm requires excision. Methods: A. Closure through arteriotomy and aneurysm repair. B. Closure through chamber. Coronary AV fistula surgical indications and results. 1. Survival. Early death. Hospital mortality, rare. Complication, rare. Time related. Late results, excellent. 2. Indications. Diagnosis is an indication for operation unless their shunt is very small, QP/Qs less than 1.3. 3. Controversies. Interventional catheter delivered occluding devices and coils have been reported successfully. Anomalous connection of left coronary artery to pulmonary artery. 1. Definition. The whole of the left main or only the left anterior descending or circumflex branch connects anomalously to proximal main pulmonary artery, or very rarely to proximal right pulmonary artery. 2. History. Brooks, first description in 1886. Bland, White and Garland, BWG syndrome. Described clinical syndrome in 1933. Sabiston, first successful operation in 1959. Cooley, bypass graft in 1966. Nachase, coronary transposition in 1974. Takeuchi, tunnel repair in 1979. Alcapa morphology 1. Connection. Left or posterior cusp of pulmonary trunk, rarely right cusp. Uncommonly circumflex branch connection anomalously. Rarely only the LAD connects anomalously. 2. Left ventricle. Hypertrophied, dilated. Diffuse fibrosis in subendocardial layer. Secondary subendocardial fibroelastosis. 3. Mitral valve incompetence. Extensive fibrosis, calcification in the papillary muscle. Dysfunction. Endocardial fibroelastosis in the mitral apparatus and LV. Fusion and shortening of chordae tendineae. Anomalous connection of left coronary artery to pulmonary artery. Alcapa, 1. Anomalous connection of left coronary artery to pulmonary artery. Alcapa, 2. Alcapa clinical features and diagnosis. 1. Infant presentation. Symptoms may be recognized within a week or so of birth. High postnatal. Pulmonary artery pressure limits runoff into the pulmonary artery. EKG, anterolateral infarct with Q waves and ST segment elevation, LVH. Chest radiology, cardiomegaly with interstitial pulmonary edema. Echocardiogram. Cine angiography. 2. Adult presentation. Collateral circulation is adequate to prevent infarction. When severe symptoms do not occur in infancy, presentation is often delayed to beyond 20 years of age. Some patients remain asymptomatic. Al Kappa Natural History 1. Incidence 2. Survival. Rare, 0.26%, 1 per 400 CHD. 2. Survival. 65%, died due to LV failure during the first year of life. LF death does not occur during the first year. The hazard lessens considerably by rich interarterial collateral, restrictive opening of left coronary artery, marked right coronary dominance. Most patients who survive infancy continue to be a risk of death from chronic heart failure secondary to ischemic cardiomyopathy. Al Kappa techniques of operation: construction of a two-coronary system, tunnel operation, Takeuchi repair, left coronary artery transfer, subclavian left coronary artery anastomosis. Other techniques for assisting reimplantation: extension by autologous flaps of aorta or pulmonary artery, mobilization with pulmonary button, coronary artery bypass grafting, ligation of left coronary artery. Al Kappa goals of surgery: establishing the two-coronary system with direct aortic implantation. Situations where direct aortic implantation is not suitable. 1. Anomalous orifices located in the non-facing sinus or in the lateral position on the left pulmonary sinus. 2. The patient is older with well-developed collateral around the pulmonary sinus. Al Kappa tunnel operation. Implantation of anomalous artery. Al Kappa implantation of anomalous artery. Subclavian left coronary artery anastomosis. Al Kappa subclavian left coronary artery anastomosis. Al Kappa surgical results: 1. Survival, early death, variable. Time related, good. 2. Mode of death, acute cardiac failure. 3. Incremental risk factors for premature death. Status of left ventricular myocardium. Important mitral incompetence. 4. Functional status, generally good late postoperatively. 5. Left ventricular function. 6. Mitral incompetence. 7. Effect of the nature of the postoperative coronary system. 8. Conduit patency after the two-vessel repair. 9. Right ventricular outflow obstruction after a tunnel repair. Al Kappa indications for operation. The diagnosis in an infant is an indication for urgent operation, and this condition in older patients as well. The mitral valve should be left alone when operation is performed in young patients, but in older patients mitral repair or replacement may be required. Al Kappa special situations and controversies. 1. Anomalous connection of the right coronary artery, circumflex coronary artery, or left anterior descending coronary artery to pulmonary trunk. Even rarer. Much less lethal. Operation is probably advisable. 2. Total anomalous connection of the coronary arteries to the pulmonary trunk. Very rarely. Symptoms appear within a few days of birth and death follows within 2 weeks. Urgent operation should be carried out. Anomalous coronary artery connection to aorta. Definition: a condition in which either the main coronary artery arises from the aorta in a site other than the left coronary sinus or the aorta just above it, or in which right coronary artery arises in a site other than the right coronary sinus or the sinotubular junction. Apparently clinical events are related to this condition only when the anomalously arising artery passes between aorta and pulmonary trunk. History. Cheetlin, Description of death of anomalous LCA in 1974. Roberts, description of anomalous RCA in 1984. Anomalous coronary artery connection. Morphology. 1. Anomalous connection of left main coronary artery. 2 coronary osteo are side by side in the right sinus mostly. Single enlarged ostium in the right sinus near to or overlying. Commissure between right and left less commonly. Coronary artery may pass posteriorly between aorta and PA trunk. 2. Anomalous connection of right coronary artery. More common than anomalous connection of the left main coronary artery. The anomalously connecting right coronary artery passes forward between the two great arteries. Commonly separated ostium, but uncommonly single ostium. Within left sinus or over the commissure. Anomalous coronary artery connection. Restriction of coronary flow. Acute angulation at the coronary takeoff. Presence of the ostial ridge, slit-like orifice. Stretching and compression of the intramural segment by the aortic valve commissure. Most recently, variable lateral luminal compression of the intramural trunk that worsens during systole. RCAs arise from the left sinus or ectopically in the right sinus. Anomalous coronary artery connection. Medical, expectant, treatment. Coronary bypass grafting. Implantation into the correct sinus from outside the aorta. Translocation of the pulmonary artery. The use of primary angioplasty in patients with myocardial infarcts. The use of stents to prevent compression. Transaortic modification of the origin and proximal portion of the ectopic or anomalous RCA. Anomalous coronary artery connection. Clinical features and diagnosis. The natural history is controversial. No characteristic clinical or electrocardiographic feature. Diagnosed by coronary cineangiography. A search is made for objective evidence of reversible ischemia. A number of cases have been reported in which serious sequelae, including sudden death. Anomalous coronary artery connection. Surgical strategies. Anomalous connection of a coronary artery, a CAR, to an incorrect sinus of Valsalva is a relatively rare congenital defect. Coronary reimplantation. Unroofing intramural segment. Coronary artery bypass grafting. Reimplantation of pulmonary trunk. Anomalous coronary artery connection. Compromised coronary blood flow. Compression of the intramural segment of the coronary artery between the pulmonary artery and aorta. Narrowing of the slit-like orifice to anomalous artery with increased aortic pressure. An acute angle of the takeoff of the coronary artery. Stenosis in intramural segment of the coronary artery, especially at the level of the commissure. Anomalous coronary artery origin. Operative indications and techniques. 1. Indication. Indications remain arguable, but reversible ischemia is an indication for operation. 2. Technique. Coronary bypass graft operation. Internal mammary artery. Saphenous vein graft. Reconstruction of proximal portion of the coronary artery. Intramural course. Division and reimplantation. 3. Results. Generally good. Anomalous coronary artery connection. Unroofing procedure. Coronary ostial stenosis. Developmental etiology. 1. Congenital. 1. Membranous obstruction. 2. Hypoplasia. 3. Atresia. 2. Inflammatory. 1. Takayasu, 8.5%. 2. Kawasaki, 9%. 3. middle aortic syndrome. Coronary artery aneurysm. Development and diagnosis. The first pathologic description of a coronary artery aneurysm was by Morgagni in 1761, and the first clinical case of coronary artery aneurysm was reported by Bergen in 1812. Coronary artery aneurysm is an uncommon disease. The main causes of coronary artery aneurysm include congenital atherosclerosis, Kawasaki disease, complication of percutaneous transluminal coronary angioplasty, and endocarditis. On rare occasions, a coronary artery aneurysm grows large enough to be called giant coronary artery aneurysm, for which a precise definition is still lacking.